Hello, everybody, and welcome to this week's or this month's NASGP educational webinar. Really delighted to be joined by Andy Whittamore, who is a GP in the next county along from our HQ in Portsmouth, and Andy's been a GP partner there for 17 years. During that time, he's developed an interest in respiratory medicine and holds a number of regional and national roles. And for the last 7 years, has spent a couple of days a week as a clinical lead for Asthma and Lung UK, and recently worked as NHS England's clinical champion for FeNO. So, Andrew, I think best to hand over to you now to explain what all that is and to and hear from you. So, thanks, Andy, for joining us.
No, thank you very much for that introduction. So hopefully my screen is up and running. I think the big thing that Richard just said was I developed the respiratory interest after joining general practice. I hated respiratory as a junior doctor. I hated it during medical school. But when I joined the practice I'm with now, they told me, well, everybody else has done it. We need somebody to do respiratory and get our cough points up. So I put myself on a course, and the next thing I knew, I was the only person GP in the area who'd done a course, and I was therefore the regional expert in asthma and COPD, which sort of dumped me in it somewhat. Sometimes it's a bit of a thankless task, and sometimes it is probably one of the best bits of the job I do. I currently split my week exactly in two. So half my week as a GP working in a large practice in Portsmouth, and the other half of my week, I'm clinical lead for Asthma and Lung UK, which I've done for nearly 8 years now. Happy to chat to anybody about the work I do there. But one of the things that has led me to do recently is the last 2 to 3 years, I've been sort of clinical lead or clinical champion for the national FeNO programme. And I'll talk a little bit more about that in a minute, because what happened was we know that they've got a technology out there called FeNO. And we knew it's been underused, especially in primary care. It's been in secondary care for a few years now. And the Accelerated Access Collaborative within NHS England, its job is to get technology rolled out further. So they sort of got me on board to sort of support them with that. And I'll come on to about what that national programme is and the sort of bits that can help you in practice and general practice in general. So what I'm going to do today is talk a little bit about diagnosis of asthma, how we treat asthma on the back of that, the national FeNO programme, and then how we actually implemented FeNO in our practice in Portsmouth, and then some information about some of the outcomes that we saw as a result of that. We've got plenty of time for questions at the end, so feel free to bung them in the chat or save them up, and we can go through that as we need to. So talking about diagnosis of asthma, and just to take it really back to basics, the WHO diagnosis is that asthma is a condition with inflammation in the airways and narrowing of the small airways. And these problems are intermittent, which means that people get symptoms on and off through their year and through their life. And I tell my patients that with asthma, it can go away for weeks, it can go away for months, it can go away for years. But if you've got a diagnosis of asthma, it's always there in the background and may catch you out. And it can cause symptoms depending on people's individual triggers, and that might be as simple as this time of year. We're seeing lots of people with the change in weather and viruses causing problems. Other people, it's more allergic, so pollens, animals, and things like that. And then there's more of the things sort of within the body as well, so where stress and hormones can have an impact as well. And what we see with asthma is whatever those triggers are, they cause certain sort of markers within the body and then within the lungs to set off an inflammatory response in the lungs. And what we see there is that then that sets off messages that include chemicals such as nitric oxide, which we then breathe out in our breath. So there's lots of things that we can measure in the blood, so eosinophils, we can measure in the lungs, such as eosinophils and other markers of inflammation and various interleukins and things like that. But actually in the breath itself, we can then measure nitric oxide. I'm going to skip the video because it's not working with sound. So a question for you all just to ponder on: how good do you think we are actually at diagnosing asthma? And the reason I'm asking the question is because actually we're not very good. One of the things that we've learned over the years, and one research study over in Canada showed that about a third of the people that we give a diagnosis of asthma might not actually have it. And that was at patients who were followed up long term given reversibility testing, challenge testing, and they found out that actually a third of people that we give a diagnosis of asthma to might not have it. The other thing I sort of warn people about is on the other side of that, we actually don't recognise enough people who've got asthma. So it's massively under-recognised, not just by us, but by our patients who might get coughing and wheezing regularly and breathlessness, but put it down to a chest infection or a virus or part of getting old, or even the fact that they smoke. But they just put it down to sort of how they are and what normal is for them. And then it's also under-recognised by cough. So if somebody with asthma hasn't had symptoms or had any medication for a year, they automatically come off the cough register, which means that you've got people who perhaps are going through a latent period with their asthma, who are then not getting an annual asthma review, they're not getting preventative medication, and they drop off the system. And then that reinforces the fact that patients then start to under-recognise their symptoms as being related to something. So for those patients who are incorrectly diagnosed, it means that they're getting treatments that are expensive, because not only do we put them on initial inhalers, but when that doesn't work, we put them on even stronger inhalers at an even higher cost. Those treatments can then have side effects, but of course, because they haven't got asthma, those treatments don't actually help. Now, on the other side of that, not actually getting treatment for the cause of their symptoms in the first place. When we're missing a diagnosis, it means that the patient's got untreated inflammation, they've got a risk there of getting symptoms, of getting asthma attacks, and a permanent decline in lung function. And of course, they might be on treatment for another condition, which again is causing them harm and not doing any sort of treatment for what symptoms they've got at the moment. And the reason asthma is difficult is because not only is it it's a variable condition, but asthma symptoms are very common and non-specific. So people get a cough, they get a wheeze, they get breathlessness, and it's very easy to put it down to a viral infection or a bacterial infection or something else. But actually, what we see then is that we start to don't delve in to try and see whether they've got an underlying condition such as asthma or COPD. And it's not just the symptoms that are variable, but the signs and the tests that we sort of examine for as well. And this is many pitfalls through the treatment and management of asthma, because actually if you examining somebody who's taken puffs of their blue Ventolin inhaler within the last 4 hours, chances are their peak flow and their lungs are entirely normal, which means you might well miss what's actually going on and need to ask a lot more questions and be more inquisitive about how their lung health actually is. We also know that tests for asthma are not performed well enough, and that's patients who don't know how to do peak flows properly, or don't do them very well, or don't take a diary as we've asked them to do. With spirometry, it's very poorly performed by patients, and the clinicians often don't push and push to get the best results out of it. And even when they are good enough, those tests are not effective enough in actually helping us to diagnose asthma. Something I quite often direct other people to is having a look at these figures, and these figures are taken directly from the BTS sign guidelines evidence base. So it tells you basically how the sensitivity in the first column and the specificity in the second column of various things that we do with asthma. We do a lot of guesswork, and that is something I think we just need to take a step back and be very reflective of. When we diagnose asthma, and when we treat asthma, and when we're monitoring asthma, we are guessing a lot of the time. We're guessing whether those symptoms are accurately described to us. We're not always asking them correctly. We're not always sort of taking enough stock of what they say. But if we look at people who are relying on symptom scores in asthma, only two-thirds of those are sensitive enough for actually picking up asthma, and it's sort of very variable within that. When we look at some of the tests, if you look at the sensitivity in that first column there of spirometry, we're relying on spirometry for actually coming up with a diagnosis of asthma and COPD, and those figures are quite stark in terms of how bad these tests are. And some of that is about how good the test is, but also how well it's performed by us in primary and even secondary care. Peak flow. Again, look at the dramatically low levels there of sensitivity. So I think it's something that we shouldn't be relying on. Very good to try and get patients to do it as well as possible, but actually on their own, it's not perfect. And even though I'm here going to be talking about FeNO and how great FeNO is, you can see from those figures that FeNO, again, isn't perfect. It might well be better than some of the other tests we've got available, but actually on its own is not good enough to come up with a diagnosis. I've talked a little bit about how the national programme was a very, very, very good thing for me. I've done lots of work with NHS England over the years, and most of it involves banging my head against a brick wall for hours and hours on end. With this programme, we were actually given the freedom to do what we thought was best. And we were given complete freedom in terms of some of the things we wanted to do, some of the people we wanted to influence, and that made a massive difference to the success of the programme. What we decided we wanted to do around FeNO was not just sell FeNO, because that was the main objection of the programme, but what we wanted to do was improve asthma diagnosis. And the first thing we did was actually set up some sort of education programs and some healthcare professional support, so that actually we could sort of take the asthma jigsaw to them. It isn't about FeNO, it's not about spirometry, it's not about everything else. It's about improving the picture that we've got so that we can be more confident and have less guesswork into providing somebody with a diagnosis of asthma. History and examination are central to that. You can't just take somebody off the street, do FeNO, and tell them they've got asthma. You need a really good, in-depth clinical history. You need an examination to sort of help support that. And then on here it says spirometry, but evidence of airflow obstruction, whether that's spirometry or peak flow, and then FeNO as well in that. And if you sort of cover those 4 boxes, you've got a much clearer picture of what that jigsaw is actually looking at. You might still need a trial of treatment, and in some cases, you might still need to send somebody for specialist tests. But actually, if you can sort of get those fundamentals of history, examination, airflow obstruction, and FeNO in place, then you can actually be a lot more accurate with the diagnosis you're coming up with. One of the things that's confused people over the years is the fact that NICE and the BTS sign guidelines do contradict each other on how you should be diagnosing. BTS sign are written by clinicians who act very pragmatically. So actually they're looking at what happens in clinical practice. And one of the reasons they don't recommend FeNO routinely is because they were aware it wasn't available to everybody in primary care. So there's a bit of a chicken and egg there. Whereas NICE has said that actually if you add FeNO to the diagnostic algorithm, then you can really improve the quality of diagnosis and be more certain about who has and who hasn't got asthma. So what we did is we actually took the asthma guidelines from NICE and we tried to turn it to something usable. Because at the moment, the algorithm is very complicated, lots of arrows going all over the place. Whereas actually what we want with adult diagnosis, as we've covered in this chart here, is you want a measure of airflow inflammation across the top there, airflow obstruction going down the side, and then seeing whether those 2 things come together and give you a certain diagnosis, or whether it's more likely or whether it's more unlikely. We'll be sharing these slides afterwards, so don't pay too much attention to this, but actually using that combination of FeNO with airflow obstruction is a good way of sort of moving forwards. And that's with children as well. So a little bit less detail in there, and any child who's got confirmed airflow obstruction doesn't need FeNO testing as well, but it is useful. There are a few things out there which also influence FeNO levels. So FeNO levels go up with levels of nitric oxide. It is levels of nitric oxide. Allergic rhinitis will also increase your levels of nitric oxide, but so will having a viral illness, doing exercise, especially before doing a test, and having an intake of which is high in nitrates as well. There are other things that reduce the levels of FeNO, and you just need to take a little bit of this into account. So smoking, caffeine and hot drinks, especially just before doing the test. Not many people drink alcohol before doing these breathing tests, but actually just bear that in mind if they have. And of course, taking inhaled oral corticosteroids will dramatically reduce airway inflammation due to eosinophils and nitric oxide. So I've talked a little bit about the national programme. I said the main thing was they actually let myself and Tom Brown, who's one of the clinicians from secondary care, to do what we felt was the most important thing. And we looked at steps, things that would support patients, it would support clinicians, it would support commissioners and people making decisions about whether to invest and provide a service. In the toolkit, and I'll share the details of where that is later, we've got all those resources from patient leaflets through to a video explaining more about FeNO for patients, through to business cases, through to AccuRx messages that you can share with patients, information that patients could do to prepare for the procedure itself, and lots of other bits and pieces in there as well. So definitely worth paying a visit there. One of the key things we did was put together some training modules. And we did 2 training modules. One is for people performing the test, because the test is so easy to perform that it can be performed by anybody with a very little bit of training. I could train any of you in 5 minutes to do it. But the important thing is how you communicate with patients, you understand where it fits into the whole pattern of diagnosing, and taking it from there. So quite often we're seeing healthcare assistants, people who don't have a profession behind them doing it. So we set up the first training module to educate people about how to do the test, how to communicate with patients, and just get the language right. So actually it was then seamless when they went from the technician place to whoever was actually doing the diagnosis. And because this was coming out around the sort of time of COVID, we were very, very careful to highlight this was a non-aerosol generating procedure, how it was safe to do, unlike spirometry, how the test is really easy and how there is some cost-effective benefits to it. And I say just supporting the whole team moving forward and using it. The second module we put together was more about how to interpret it. So there's lots of case studies about how to use FeNO as part of the diagnostic algorithm, to put it together with the other tests and taking a good history. And it was really to be done by GPs, by consultants, by nurses, by physios, by pharmacists, so people who are in a position to actually make a diagnosis. The first module, as I said, really easy, very simple, very straightforward, takes about 20 minutes to half an hour for somebody just going through it at their own pace. There's a simple knowledge test at the end, and it's just really to check that you have taken in what's going on, but there isn't any pass-fail threshold along with that. The one on interpreting FeNO, because it is around the diagnosis of asthma, we set a level that people had to pass a test and get 80% to pass. It is extremely easy. If you don't happen to pass it, you can retake it at any time. And when we sort of got feedback from all the people who'd been going through the program and doing the test, what we found is that probably about 3/4 of people found it was acceptable and okay or excellent and very easy. We found about 1/4 of people found it extremely difficult and said it was well bit out of their comfort zone. And when we delved into that, we found that was people who'd been thrown into respiratory without any training or support, and they didn't actually know what they were doing in the first place. As I said, we've got lots of other sort of resources there as well, so leaflets in a variety of languages, also audio versions, accurate messages with links to how to prepare for the test and more about the test. And we put together a video for patients as well, which is hosted on the Asthma and Lung UK website. Lots and lots of feedback. So FeNO has been a game changer for some PCNs and practices. In our own practice, the practice nurse I work with, who's been in asthma for a long time, is a trainer, so she's extremely experienced. She found that FeNO challenged her. She didn't realise how often she was guessing with her clinical judgment and how often she was actually wrong. So she had a bit of a crisis of confidence for a month or so, and then learned to embrace FeNO and start work with it. But what it really did highlight was how much we are probably getting wrong. Even the good people who understand asthma and diagnosis, were getting it wrong, and actually how much we do rely on guesswork, unfortunately. So as part of the program, we had 33 national projects. They've all been written up now, and they're all sort of collected, and there's a repository of all those within the toolkit. Many FeNO tests were done, and we examined whether they made a difference to people, whether they made a difference to clinicians, and also whether there was cost benefit at all. I think one of the most dramatic outcomes from the project is we started to see that the ball started rolling. Practice started taking on FeNO. Practices around them decided they wanted FeNO. We had whole healthcare areas, so the whole of Yorkshire, the whole of Humberside, the whole of the Southwest, all adopted FeNO across all their practices. And this meant that actually the manufacturers of the FeNO devices actually started slashing their prices. They didn't need the high margins to actually get their machines out there. One of the reasons why NICE struggled with FeNO initially was the high cost of each test. And now we've seen that cost come down absolutely dramatically as a result of this program. So coming on to our own experience in our practice, We'd wanted FeNO for a long time, and this gave us a great opportunity to try and engage in it and try and invest in it. We knew that FeNO was becoming mainstream, and because we were coming out of COVID, people weren't doing spirometry, so we wanted something to help to pin our diagnoses on. We also knew over time this would improve the quality of the diagnosis. As part of management and monitoring, it could also improve what we were doing there. And with morale in respiratory and across the NHS being so low, actually providing them this new test to help support them was a real good boost to their confidence as well. So the first thing we did was, unsurprisingly, we tapped into all the resources that there already. So went into the toolkit, we used the education, we had extra training from the manufacturers, we used the pathways, and the manufacturers actually supported our clinics in the first instance. We used the patient information leaflets, the AccuRx, the Ardent templates, all to try and make sure that we were capturing the work we were doing as well as possible and make our lives as easy as possible. And we did a little bit of an audit of the first 300 or so patients. Firstly, one thing I'd say is spirometry is really hard for people to do. They take training, they take coaching, and it can be quite arduous. And quite often they don't do it very, very well. We found that 97% of our patients could do FeNO on the first visit with a little bit of coaching. The age range was very, very wide. It's very hard to get somebody under the age of 12 to do spirometry, although you can do it from the age of about 7 or 8. With FeNO, we were getting children as young as 5 doing it, and with a lady aged 85 who managed it as well. And the range of FeNO levels we came out with was less than 5, so very, very low, up to 178. And just to come back to where diagnosis sits, so for adults, diagnosis any levels above 40 is abnormal, and for children above 35. And we found, when we sort of asked our clinical team whether it made a difference, 69% said it actually made a visible difference in terms of how they came up with a diagnosis. In a significant number, it also helped with decisions on medication as well. When we looked at what we'd done with various patients, it supported us to increase or initiate inhaled corticosteroids in just under 50 of them. But I think the most telling thing was it actually helped us to not start steroids in another group or to reduce or stop in a significant proportion as well. What FeNO also did is, because we're able to assess whether somebody's got any evidence of airflow inflammation at the time, it gave us the opportunity to have conversations with patients. So telling them about what the disease, what the test was going to be showing. So if we were telling them this test is going to show evidence of airflow inflammation, it means that you're getting enough steroid, or you're not getting enough steroid, or you're going to need steroid or not need steroid. Then what it did, it opened up the conversation. So actually patients were saying, you know what, I'm going to have to be honest with you, I've not been taking my inhaler properly. I've not been taking it regularly. And that was something that our team found very, very useful. Even by telling what the test was going to show, the patients would then open up and be honest about their own adherence and perhaps inhaler technique. A significant number of patients needed referral to another clinician. The main reason for this was we were showing an absence of airway inflammation when patients were getting chest symptoms. As I said at the beginning, asthma symptoms are not very specific. People get coughing, they get breathless for all sorts of reasons. And the default is to come to us and change a prescription. The default for us is to increase their inhaled corticosteroids or change their medication. So actually what this was doing was saying this group of patients do not need that. They need another diagnosis looking at, or they need another set of tests doing. Very high levels, even though we could prove patients were using their inhalers properly, led us to accelerate referrals into a severe asthma clinic. We got feedback from our team, and most felt that actually spirometry was significantly harder than FeNO to understand, to explain, but also to do. And also the numbers didn't seem to mean anything to patients with spirometry. Whereas with FeNO, patients were coming back and asking what their numbers were, in the same way that people might ask us what their blood pressure or cholesterol or HbA1c would be with other conditions. So actually it was really useful for the patients to actually engage in their condition and understand what was going on. As I said, it's very useful at starting discussions about whether they're using their inhalers correctly. And it really focused a consultation and gave us a proper objective measure that we could use and to help steer the conversation. So very similar sort of feedback there. One patient was significantly what appeared very poorly controlled severe asthma. actually reflected on the results, even though he was using all the medication all the time, regularly and correctly. When we showed him, he came and said, well, my low FeNO probably means that my symptoms aren't due to asthma. Maybe there's something else. Maybe it is the anxiety that I think I've got. So actually patients are starting to sort of interrogate their own disease and their own behaviours to try and understand what the result meant for them. And others, as I said, it outlined to them that perhaps there is a benefit to using their inhalers regularly because it suppresses the inflammation, and you can actually measure that on FeNO. Similarly, when you're starting patients on treatment, when the numbers then change after a few weeks, you can be more confident and the patient can be more confident, at least we're doing the right thing for their disease. And similarly, we did that with other patients where we were reducing their inhaled steroids because it didn't sound like asthma, and their FeNO stayed low or stayed within normal limits. So a couple of quick sort of case studies. We've still got time to do this. So we had a 7-year-old girl who'd been getting persistent symptoms for 3 or 4 years. Because of her age, she hadn't really done much in the way of any objective measures to support her diagnosis. Some clinicians thought it was viral wheeze, some thought it was asthma. She'd been given different inhalers over the years to try. And her peak flows are pretty useless, actually. Mum was very reluctant to have medication because actually she didn't have as much faith in the diagnosis, but also the process, and the inhalers didn't seem to work when she was taking them. And by getting a FeNO recording which showed a level of 83, which is high, so it's above sort of 35, then what it showed to Mum is we were on the right lines in thinking that she might have asthma. And it actually allowed us to have that discussion about starting some medication, explaining that low-dose inhaled corticosteroids are actually safe and they're effective and they can make a big difference. And even with some skepticism, she then did that but came back, and we could show a big improvement in that FeNO level. So 19 is on the low side, so showing that we've suppressed the eosinophilic inflammation there. So in this case, it showed us that we could get more effective use out of medications. We had greater engagement from the family, and then we were reducing potential harm from somebody starting and stopping medication over a period of years. Similar, another 7-year-old girl, she'd been on salbutamol for 4 years, and it seemed to help. She had a 3-month trial of inhaled steroids, but the parents weren't sure whether it was any good, so they stopped it, which is reasonable, but they didn't do it with consultation with us. Then she came back in with a chest infection, and Mum said, well, could it be the asthma? She was unable to do peak flows consistently. FeNO level came back very low, even though she was asymptomatic. So whereas I think previously I would have been tempted to get another trial of treatment to see how things go and keep trying with peak flows, this gave me and the parents and the child confidence that actually asthma was less likely. So we didn't start inhaled corticosteroids. We talked about sort of effects of having a virus and so on, and sort of managed it further from there. So in this case, we didn't prescribe an necessary medication, and we were confident that she didn't have asthma. Now, this one was a 7-year-old boy. He had, again, chest symptoms since he was aged 1. He'd been diagnosed with asthma about that sort of time, based purely on his history. And over time, he kept coming in with his mum, and Mum was saying his asthma isn't very good, he's getting symptoms. So we escalated him up to higher doses of steroids. We got him onto combination therapy with serotype. We added him onto Lucast. When he came in and he felt that his symptoms weren't very good, we were giving him prednisolone when he was unwell, which in retrospect were viral symptoms. Because of the symptoms he'd been getting, he'd gone through 49 salbutamol over 6 years, which is much more than we'd normally recommend. And when we sort of interrogated him a bit more, and actually taking a good history is so important here, we found actually his main symptom was he was getting breathless when he was playing football. Now, I'm not sure how many people here do football, but if I got you to run around in the pitch, especially today, I suspect most of you would be quite breathless doing it, especially if you're playing competitively. It felt to us like there was a bit of a learned behavior going on. And actually, when he was getting breathless, he was taking his SABA, he was treating it as if it's asthma, and there was a bit of a vicious cycle there. His FeNO when he was symptomatic was 7. So this could be that actually his medication is working really well and suppressing all his inflammation, or it could be that he hasn't got asthma in the first place. What we decided to do is we sort of worked with Mum and with the child as well, because he had a big investment in feeling well and was worried about his chest because he was told it could kill him if it wasn't looked after properly. We reduced his treatment and tried to sort of monitor how things were going on. After 4 weeks on the lower dose, his FeNO hadn't gone up substantially. It's still well below where we'd be worried about it. So anything sort of 30 and above, we'd be thinking might well be relevant of having some inflammation there. And that allowed us to go for a further reduction. So in this case, we managed to stop unnecessary medication. We were reducing the potential harm. And actually, if you look at how much time and money and medication was using, there was significant saving there in terms of saving the NHS resources. So overall, I think the benefits from FeNO for primary care is that actually we showed that you can get more accurate diagnosis of untreated eosinophilic inflammation, which means you can target treatments better. You're getting more bang for your buck in terms of the treatments you're giving out, and there's less guesswork, so you're not wasting it on people who perhaps don't need it. You've got more evidence when you're escalating or de-escalating medications. You can speed up deciding whether patients might benefit from referral for biologics if they've got significantly high FeNO levels despite the treatments that you've given them. And also considering whether different treatments or diagnostic changes for people who've got COPD as well was also something we came to. The biggest thing for us, it gave us great certainty of what we were doing and actually allowed our patients to have greater confidence in us and in the medication as well. We did some cost analysis of all the children that we looked at. So I think there was about 51 patients here. And one of the reasons we did this for the NHS England work was at the moment, there's this disincentive for primary care to invest in these tests. Primary care are not paid to do spirometry, they're not paid to do FeNO. We just paid to document that they've had it done and to get it into QoF to actually give us those points and that funding. But actually, we've got no investment to support us actually doing these tests. And what we wanted to do was actually prove there's actually a cost benefit for primary care doing it. Saving costs from medication or admissions, that saves it for the whole system. It doesn't help primary care at all. But what we found when we just examined the paediatric cohort, and we're currently examining it for the rest of our patients as well, is actually, in terms of the staff savings in primary care, there was definitely a benefit to doing FeNO. So even though the most savings come from what you're saving in terms of medications and admissions and how the rest of the system will benefit, what this showed was actually there was a small but definite benefit for primary care. And actually the cost per test that we found came to just under £10. The cost per patient per staff savings, the average came out over £12. So actually there's definitely a benefit there, even if it's not massive. Something in my work with Asthma and Lung UK, we recently commissioned some work from PricewaterhouseCoopers looking at the cost of respiratory diseases to the NHS and to the UK economy. And one of the findings from that was if we implemented FeNO for diagnosis and monitoring across the whole NHS in England, then we would save almost £100 million, allowing us to optimise asthma treatment in different ways as well. So hopefully these findings, not just from the local projects and what we've done at Portsmouth, but also through the PricewaterhouseCoopers work, is hopefully going to be able to influence not just the guidelines that come out next year from NICE and BTS, but also going to influence people who are deciding GP contracts and things like that. So actually we can then start to reward primary care for doing tests that will save the NHS money. I said all these slides will be available afterwards, but there's a couple of links there. One is to the Primary Care Respiratory Society, who are now hosting the FeNO toolkit for us, and all the resources that I talked about, plus all the case studies of where it's been used, are actually hosted on there. And then the PricewaterhouseCoopers report is hosted on the Asthma and Lung UK website. So I think we've got plenty of time now for questions. So feel free.
Thank you, Andrew. That was really, really interesting. And we've got one question so far from Wendy, but anybody else, please do put your questions in the chat. But can I just ask you one sort of fantasy, but in terms of GP locums working in lots and lots of different practices and coming to meetings like this, I think we can be in a very good position to spread best practice. And do you think that the data now is compelling and strong enough? And you've obviously mentioned the toolkit and resources from the website, but do you think if I was locuming in a practice and a practice wasn't using FeNO testing and I was thinking actually this could be really good, could I be confident in saying, look, if you don't do FeNO testing yet, it's a really good tool. Here's the website. I'd highly recommend you kind of get on with it. Do you think that's robust enough at the moment?
Yes, I do. One of the things that we regularly get challenged, because I think there's lots of reasons why FeNO hasn't taken off. The main reason is funding. The second reason is when NICE suddenly announced it a few years ago, it was sort of thrown to GPs that you're doing a really bad job. FeNO will improve things. Your clinical judgment isn't good enough. And the third thing is when I showed you those data tables, it showed that FeNO sensitivity gets up to about 80%. So I get fed back from a lot of GPs saying, well, why are we doing this test if 20% are going to be wrong? And that's where I say, well, there's two things to that. If you look at actually how effective peak flow and spirometry is, FeNO is better, but yes, not perfect. But secondly, it's about that jigsaw approach. You do need to look at history examination, airflow obstruction, and airway inflammation, all in combination. And even then, you still need a trial of therapy sometimes.
Yes, so it's triangulating it, isn't it? It's taking those different approaches and building up a richer picture.
And the other thing to say is going back probably about 7, 8, even 10 years, there were lots of little pilot sites testing out FeNO. And one of the reasons it wasn't cost effective and didn't work very well is because they were doing it on everybody. I think the question from Wendy is almost sort of hinting at that, is actually if one of the problems is if you can't do it for everybody for monitoring, because what you find then is some people have actually got their levels suppressed, so you're not actually proving anything.
Oh, I think, Andy, you might have frozen, or even while you're frozen, I'm going to read the question out in case people are watching the video, they might not be able to see it. But Wendy's asked, given that asthma is intermittent, is FeNO still reliable for diagnosis when no asthma symptoms for a few months and tested during this time? Would this give a false negative?
In a lot of cases, we actually proved that it wasn't necessary and wouldn't help. So actually, we were saving the patient hassle. We were looking at their right diagnosis and taking it forwards.
Okay, thanks. You froze for a little bit there, but
yeah, I had a bit of an internet issue from the sound of it here, so yeah, bear with me.
Blame it on on the storms. No, thank you for that. Got another question from Shanaz. Shanaz says, do you have to stop steroid inhalers before FeNO testing? And if so, how long do you need to be off the inhaler for?
Okay, so what I'm going to do is, just to be fair to Wendy, I'm actually going to finish her answer a little bit there. So you can get false negatives with FeNO. And certainly if their inflammation has died down, whether their triggers aren't present or for whatever reason, then it comes back to the history. If you're strongly suspicious that they've got asthma and their symptoms have gone down and the inflammation levels have gone down, then I think it's basically waiting till the symptoms recur and then repeating FeNO at a later time. But their FeNO is low and there's no evidence of airflow obstruction either, then it means that asthma is extremely unlikely. So actually it's about revisiting the diagnosis and considering what else it might be. If your history and examination still tells you this is likely to be asthma, then keep revisiting the question from time to time. You might need to revisit the FeNO at a later date as well. In terms of Shanaz's point about do you need to stop steroid inhalers before a FeNO test, for diagnosis, it's mixed. I mean, at the moment, with all respiratory testing, spirometry, FeNO, there is usually a delay for getting it done. And the asthma guidelines all suggest treat people's symptoms when they get them. So quite often you've started them on treatment before they've actually gone for the tests. It takes about 4 weeks for you to get the full benefit of the ICS to reduce FeNO levels. So it might well be that if you do the test in that intermediate period, you still get a slightly raised level. But I think the thing is, if your FeNO levels come back low and their symptoms seem to have disappeared, then it might well be worth reducing or stopping an inhaler for a few weeks and then repeating the test then. So I hope that answers that question.
Lovely, thank you. And Shanaz got a couple follow-up questions. Do you have to include the ACT score, and how accurate is this? And then many people also, Shanaz also asked, many people have hay fever and allergies, so how do you interpret the FeNO result, I guess, in that context?
So the ACT score is measuring symptoms. And I think when it comes to diagnosis, the ACT score isn't relevant because you don't know whether they've got asthma. You need to prove whether they've got inflammation and obstruction. and then use the ACT. I generally use the ACT for monitoring symptoms. If somebody's got poorly controlled asthma, so you know they've got the diagnosis and their ACT score is reducing, then using FeNO to prove whether those symptoms are truly due to asthma or not can be quite useful. So they're looking at different things, so use them in combination depending on what your clinical history is telling you and the point on the patient journey that they're at. In terms of allergies, especially rhinitis, you do need to be careful. So if a patient is getting both chest and nasal symptoms, you might need to take a view on which one you treat first and what you're going to measure as a result. If you're persistently getting high levels of FeNO and you've treated their chest, then obviously treat the nasal symptoms as well. So yeah, in combination, sort of consider both, but you might just need to sometimes just put your finger in the air and just say, I don't know which one is causing it, but this is the one I think. And again, that comes then down to history and examination. Are they getting predominantly chest symptoms or predominantly nasal symptoms?
Lovely, thank you, Shanaz. I hope that helps answer your question. So Shanaz says, so FeNO used to diagnose and monitor asthma. Okay.
Yeah, so the national programme was used to diagnose asthma, but a lot of the sites were using it to monitor as well. I said the previous pilot sites going back a few years basically proved it wasn't cost effective to monitor everybody. And as we've had some questions so far, if somebody's not got any symptoms, chances are they haven't got any inflammation. So there's nothing really worth testing there. If they're getting symptoms and they're poorly controlled, or they're on very high levels of medication and you want the confidence to help reduce it, then sometimes it can be useful. Well, it can be useful to use FeNO to help reduce.
Oh, lovely, thank you. And anybody on the chat at all got any of their own experiences of using FeNO? Has anybody been using it? Have they found it useful? Has it changed the way they practice or prescribe? Or any other tips or feedback for Andrew at all? If anybody has, put something in the chat and I'll call you through. But if not, then otherwise, I think we've done perfectly in sticking to our 45 minutes. Andrew, is there anything else more you'd like to add that you want to elaborate on at all before we go?
No, I think I covered everything. I was hoping to get time to cover some new changes in terms of treating asthma, but maybe that's for another time. There was some research out recently showing that, so for people who are familiar with MART inhalers, so where you use formoterol containing ICS inhaler, it's a useful way in helping to manage people with asthma symptoms. There is now evidence showing that actually it can be used first line at diagnosis and in people with mild asthma. So people using intermittent MART effectively, so without the maintenance bit, and using that regularly to help monitor, sort of maintain control of their symptoms. So you're going to be seeing a lot more of that with articles in the BMJ and guidance and local guidelines coming soon. But yeah, lots coming in that direction shortly.
Well, that sounds like a promise then. It sounds like we should get you back and talk more about this, because obviously it's such a common presentation and something we deal with so much in general practice. And as I think often as locums as well, we're seeing those acute presentations and often seeing follow-ups as well. So it would be that could be really good. Anna has said very helpful. Thank you very much. And Shanaz has also said thank you as well. So. Andy, thank you so much for coming along. Really appreciate you spending this time devoting your lunch hour and talking to us today. It's all being videoed. It'll be out on YouTube and we'll be able to share it much wider with colleagues. So thank you very much. And thank you very much, everyone, as well, coming along as well. Look out for the email digest on Monday. We'll be sending you some updates about the next talks we're going to be having. And yeah, see you all soon. Thank you very much. And cut. Thanks, Wendy. Lots of people leaving. That's wonderful. And thank you so much for that. Did that go all right? All go all right for you?
Yeah, apart from that little blip with the internet just towards the end, but yeah, otherwise good.
I think we're all used to that these days. I think our brains have accommodated now, haven't they, to sort of filter those out. But yeah, but no, that's great. And you mentioned I'm not sure if we've got the slide deck or not as well, but we can obviously we can share that.
I haven't shared it with you yet, so yeah, I can send it through.
Yeah, we can definitely include that as a link. But yeah, and I think a further talk on asthma and lung. Do you think that we've got another 45-minute potentially to?
Definitely, especially the Mart stuff.
Yeah, no, that could be really good. No, and that was a great format and great slides as well, really informative. And there's a lot of stuff to take home there. We've got quite a nice. That's quite good for us to have 20 people on the attending the meeting, and then obviously it goes out on YouTube as well. So lovely. Yeah, thank you so much, Andrew.
No, thank you very much.
You take care.
Thanks, Andy.
Yeah.
Bye.
Cheers, everybody.